All right. So I'm Brett Klein with Eisenhower Health. Welcome to our lecture with orthopedic side of the house. And Dr. Cassim will get going here momentarily, beyond the pain and talking to you about all things related to pain. And so with that, just as a note, please keep yourself muted and your video off at the time being. This is being recorded. It will be posted online once it's edited in the next couple of weeks on the Eisenhower Health .org website, as well as a YouTube channel. So, and we'll send it out to everyone who registered. We will hold any questions until the end, and so please use the chat feature to ask any questions as we go along. All right, with that in mind, Dr. Cassim, it's all yours.
All right, thank you, Brett. Thank you very much. Everyone here in the audience, good to see you. We have a lot of people on Zoom. Thank you for logging in. And I know Brett will figure out a way to get the questions in at the end. All right, beyond the pain. Pain is actually your body talking to you. Pain is when you fall down and your knee hurts. It's telling you, be careful. Pain is when you have chest pain, you go to the ER, it's telling you you need to get that checked out. So pain actually has a purpose. And we call that acute pain. So pain with a purpose is a good thing. It tells you something bad's happening in your body, let's go get it fixed. Pain is your body talking to you, telling that something's going on. You go to the emergency room, you get it checked out, and that pain is called acute pain. It has a beginning, it has a middle, it has an end. Sometimes pain lingers on. You've had that back surgery and you're still in pain. You've had some knee problems, you're still in pain. And usually if pain lingers on for more than 3 months, that's the bad pain. That pain has no purpose, and there are a lot of changes on the cellular level. We have fancy medical terms, central sensitization, peripheral sensitization, essentially meaning that your own body is now working against you. It affects you physically, affects you emotionally, and it is really the number one reason most people are suffering. It's the number one reason for people to go on disability, number one reason that people can't go to work. It affects society in billions. But we really can't quantify how bad it is for a person. Individually, people are suffering. And we have just a number 1 to 10 that everybody hates to fill out because that makes no sense. But that's the best way we have to quantify pain. From the beginning of time, this is a hieroglyphic papyrus which shows Egyptians 5,000 years ago trying to fix pain. Since the beginning of civilization, we've tried to fix pain, and they talk about cannabis, they talk about opium, they talk about multiple things that we're using to this day to try to solve this problem called pain. And today we know so much. We know the spinothalamic path, we know the thalamus, we know about the brain, we know about all these different things about pain from a cellular level, but we still have problems. And today the problems are also stemming from the fact that we have too many choices. So if a patient has pain, you go to one doctor, they'll tell you, here, take this salve. Another doctor will tell you, take these peptides. Another doctor will tell you, here's an injection, right? So as patients, as physicians, as society, we have so many choices. Makes it even more difficult in terms of finding the right options and the right path for people to get to a place where they're functioning. So the goal today for me is to really make it simple. I'm going to break this stuff down, make it easy to understand so that you have some of the basic knowledge to make decisions and hopefully find solutions. The general consensus today is when we're treating back and neck pain, there's no one solution unless it's acute pain. So if you have acute pain, meaning something that just happened within the first 3 months, you're going to the ER, there's a problem, let's fix it, you're good. Gallbladder, appendix, broken bone, heart attack, those are all fixable things for the most part. But if we're dealing with a chronic issue, you need a comprehensive treatment plan. That means multiple types of treatments at the same time. Medications have a role, muscle work, stretching, strengthening, home exercises, core exercises, behaviors, Golfing every single day is not going to help. Maybe golfing once a day, and different types of behaviors need to be changed. Alternative treatments also have a lot of evidence behind them. Today's discussion is focused mainly on direct treatments. Even though all these treatments are needed, the most controversial and one of the most important areas to get quick relief and sustained relief is with direct treatments. And we're going to talk about direct treatments. And again, for all the different treatments we mentioned, one thing we all need to look for is called evidence-based treatments. And what does that mean? Whether it's medicines, whether it's injections, whether it's alternative treatments, can we replicate it? If somebody has knee pain and you get this medicine for it and it helps them, what if you gave that same medicine to different people in different cities and study that? Do we get the same result? That's a multi-center trial that's going to help figure out if we're on the right track to help people. And that's how we get evidence-based treatments for problems. So what I'm going to talk about today is evidence-based treatments for direct treatment or interventional therapy. This device here really revolutionized pain management. So if you look at this, this is an X-ray machine. It's a mobile portable X-ray machine. We call it a C-arm because that looks like a C-arm. So this tech looks at the screen and we can send X-rays across this and see whatever structure we want. We can look at the joints, we can look at the back, and we can look at multiple structures that way. Now, this is an individual who's laying down on the bed, and you can see their back right there. And this is how we do our interventional treatments. So when we do direct treatments, these are X-ray or fluoroscopic guided treatments where I'm having a patient lay down, and here's the tech using the C-arm, and I can see exactly where I'm going. That's why these treatments are amazing. I can look at the structures and put medicines within millimeters of each other. The spinal cord is just a few millimeters from the dural space. So all these very subtle changes can be identified and we can treat them appropriately with this C-arm. So today I'm going to make things very simple again so that we're going to build it from the bottom up. We're talking about where are we treating and what are we putting in that area. And I'm going to break this down in a very simple way because we should all understand what's going on. In medicine, we have this amazing practice of 50 different names for the same thing, confusing not only patients, but multiple physicians as well. We like to sound smart, so we call the same thing by 20 names. So what we're going to do is just make it very basic and then build up so that someday you will look at a treatment and say, okay, I get this. Now let's look at the evidence. Is there evidence? Okay, this is for me. So we're going to start off with where are we going to treat? So the first thing we're going to talk about is the epidural space. The epidural space is a famous area. We've heard it many times in many different things. And then we're going to talk about the joint spaces. Those are the two common things causing pain in back and neck. The epidural space, yes, that's a stack of pancakes. So if you look at pancakes, which I like, we've got pancakes separated by fruit and these different layers. That's how the spine is structured. For the longest time, hundreds of years ago, people believed that the brain and the spinal cord were just floating in your body. But we realize that's not so because those are the only parts of your body that don't recover so well. So if you have a broken bone or a trauma to you, you heal. But if you have an injury to the spinal cord, you're paralyzed. Or if you have an injury to the brain, there's a stroke. So these areas of your body don't recover that fast, so they need to be protected. People didn't realize that the spinal cord and the brain were protected not by one big structure, but multiple structures stacked on each other, and that's the vertebral column. So kind of like our pancakes, the vertebral bones are right in the middle. Those are the discs. So this is side view. This is somebody standing like I am facing that way. So each stack of pancakes are the discs and the fruit, which is a lot harder. It's a bone, is the vertebral bodies. They stack on each other, and essentially there's a hole where the spinal cord runs, and that's right all the way through. So this here is the neck. It's called the cervical spine, thoracic spine, lumbar, and the sacrum and coccyx right down there. And if you can see this curves in the spine, these are the natural curvatures. The lumbar lordosis that bends backwards, and the cervical curvature. These are the normal curves of a vertebral body that protects your spine, and those are very important for body posture and mechanics. Now, if we take a closer look at this, and again, we're going to go cross-section of somebody's back, that's the front, and we're going to get very close to the lumbar spine and expand that area. When we expand that area, what we see is the vertebral bodies are right here, and the pancakes, which I like to call the discs, are there, and the spinal cord running all the way through. So I'm going to do a little slice of that and take a cross-sectional view of this. When we do that, we see the spinal cord, and that's the dura, which is the covering of the spinal cord. And the spinal cord and the brain are always floating in fluid. It's the CSF, or cerebrospinal fluid. The epidural space is an area just above that. So if you're getting an injection, the skin gets anesthetic just like that. Then we put a needle that goes in deeper right into that spot. That's the epidural space. Epi is above the dura. And the beauty of that space is that it's very close to the spinal cord. So any medicine you put in there has less side effects because it's not going through your mouth, it's not going through your liver, it's not going through the, the cleaning systems of your body. It's getting right to the spinal cord. So you need a small dose. It's much more potent, less side effects. So if you're having a baby, we go to that space and we put in fentanyl, pain medicine, and bupivacaine. So that's an epidural during labor. And if you're having an epidural for pain, we could put in a whole bunch of stuff, corticosteroids, stem cell, platelets, and we'll talk about that. But it's very important to understand what we're talking about. So when we talk about an epidural, it's a place. It's the space above the dura that we just saw. Now, even though the vertebral body is very important in protecting your spine and brain, there can be problems due to aging and time and movement and activities and genetics. And that causes about 70, 80% of the issues. So again, same structure, okay? My pancakes here. This is somebody in the front and that's the back. So on top, the pancake, which is the disc, is sitting right there. You could have a degenerative disc, which is arthritic disc that's flattening. Let me jump back in there. You could have a bulging disc, as you can see there, herniated disc. You could have thinning disc. You can have osteophyte formation. All those are just the 50 different words meaning arthritis. So again, that's how it all gets confusing. You could have a degenerative disc, osteophyte formation, degenerative disc disease. All of that means arthritis. So if you look at an MRI, again, same thing. Now you can understand the MRIs a little better. Here are my pancakes, the white discs, and that's the fruit or the bones, which is stronger. This is the spinal cord coming, and you come down like, what is this? That's a big disc. This disc, which is the pancake, has gone into the canal. That's a herniated disc. You could call it a sequestered disc, you call it a bulging disc, but essentially it's squeezing the nerves here, and that's going to cause problems. And what are the problems it can cause? Well, many. It can cause shooting pain down your legs. And again, we call this sciatica, radiculopathy. And essentially, the disc herniation, or whatever's pushing into the canal, is pinching the nerve. And the word for pinching or narrowing is stenosis. So what we have in your spine is a narrowing of the spinal cord due to whatever the reason is. It could be a herniated disc, sequestered disc, osteophyte formation. Something is pinching the canal. Now, if it's just shooting pain down your legs, okay, not bad, we can work with it. But if you have weakness, bowel bladder issues, numbness, those are bigger concerns. That could mean it's squeezing the cord itself, and that's a different story. So again, you can see that there's a spectrum or a range in what can happen because of these nerves being pinched. So going back a little bit away from the medical stuff to the purpose of epidural space, how do we know we're in the epidural space? And you can, so this is somebody facing the other way now. These are the pancakes, and that's a needle. You should have black stuff. The black stuff is very important. It's contrast dye. So whenever we do an injection, we put in this contrast dye that lets us know exactly where we are. So using fluoroscopy, 99.9% of the time, we know where we're at. That's how, with the C-arm and the contrast dye, we're certain of where we're getting the medicine. So again, epidural space from a side view, from an AP or front view. And this is the same thing. This is a transforaminal epidural steroid injection at L5, where we see the L5 nerve root coming right out. So again, this is the sacrum. This is my needle. So right here, with that picture, we know where we're at. Now, nothing's being put in. This is just the where. And after you get that image, you can put anything. You can put stem cells, you can put steroids, you can put platelets. So again, we're just talking about where we're going. So that was the epidural space. The next big area that causes back pain and joint and hip pain are the joints. So here's a guy standing, and let's take a closer look at his pelvis. So if you look right there, when somebody's standing up, these are his femurs, or the heads of the femurs. That's his hip bone, right? Right here is the spine. These joints right here, where I'm showing you the sacroiliac joints, big cause of low back pain. All these little joints on the sides, which are the facet joints. Facet joints are a huge cause of low back pain, because when these pancakes are stacked on top of each other, they are connected with little joints called facet joints. That's why we can move and twist and we're not rigid. But those joints, again, trying to protect you, can cause more problems. So that's the hip, that's your SI joint, and those are the facet joints. So let's say we were doing an injection in somebody's hip. This is the hip joint. There's a space in any joint, even the facet joints. The facet joints are mini joints, but they have space, they have a cushion, and they have fluid, right? And that's a needle going right into the joint space, or the capsule at least. And again, the contrast dye tells us where we're at. So between the C-arm and the contrast dye, we really know where we're going. That's again contrast dye. And if you look at this, this is somebody, again, sacroiliac joint. You have a beautiful outline of this joint. The sacroiliac joint is a huge joint in the low back. It goes anteriorly and posteriorly, front and back, causing a lot of problems. So the facet joints, again, with my pancake talk, goes all the way from the neck to the low back. The cervical spine, thoracic, and the lumbar spine are full of facet joints right here, multiple joints, one on either side. And those joints, again, help you bend, twist, move, but due to injuries, activities, genetics, they can degenerate. And if you look at this, again, side view, these are the pancakes, this is the fruit in the middle, or the vertebral bodies. And these joints, if you look here, that's an arthritic joint, which we like to call, again, side view, spondylosis. So if you hear the word spondylosis, again, that's us using 50 different words to explain arthritis. Spondylosis, degenerative disc disease, arthritis. Spondylolisthesis is a type of arthritis, but essentially what that means is, this segment is slipping on the one below it. So you have a slippage in addition to arthritis causing pinching of your nerves. And degenerative disc disease is again, a bigger umbrella term for all of that. Now, with the C-arm, there we go. That's my little needle. That's a facet joint, and that's the contrast dye telling me we're in the right spot. So we looked at the two most common locations in the back, the joints and the epidural space. Okay. Now we're going to talk about what do we put in these areas. We can put in steroids, we can put in heat, we can put in electricity, we can put in platelets, we can put in stem cells. A lot of stuff, a lot of choices. And how do we decide what we're going to do and where we're going to put these medicines? And that's where the clinical stuff comes in. We need a good diagnosis. We need to see the patient, get a history. We need to get an exam. We need to get imaging, testing, MRI, SPECT scan, EMGs, and patient goals. Some people may have arthritis in your back, but you can function, you can move, you just can't golf 5 days a week. Okay, maybe we golf twice a week. There, you're happy? Perfect. But if you can't do the daily things you need to do to survive, that's a problem. So let's talk about the first and the most common medicine we use. It's called steroid. There are two big types of steroids. Anabolic steroids, those are what the bodybuilders use. That's not what we're talking about. Corticosteroids are anti-inflammatory medicines created by our own body, and we have actually used them. We use them for multiple things. Oral steroids for sinusitis, allergic rhinitis, lung issues, multiple things. But the problem is if you take it by mouth, again, goes through your liver, goes through your body, causes a lot of side effects, not as powerful. But if you take the injectable version, using the C-arm and the contrast dye, put it in the epidural space, put it next to the facet joint, much more potent, better outcome, less side effects. This was the gold standard for the longest time, and this was the stuff we always used. Many different types of corticosteroids, depomedrol, methylprednisone, all these steroids or corticosteroids, these are names. So when people say, give me a cortisone shot, these are the types of cortisone or steroids we use. So steroids still continue to be the gold standard. We use that as a good first step. And if people get good relief, months, and they're able to strengthen your muscles, that's the key, right? The injection is not the solution. The injection is a tool that gives you time to strengthen the weakened muscles that's making your pain worse. That's a very important concept because a lot of people come for the treatment, which is all these fancy things we can do. We got fancy, but you have to strengthen the muscles because when you're in pain, you're walking different, moving different. You're not using all the little muscles in your back and your core. So those muscles, the baby muscles that are important for stabilization, important for standing, they're called the erector spinae multifidi muscles, they get weak. They get weak quickly. So by doing some of these interventions, we reduce your pain to the point where you can strengthen them appropriately. So if I do an epidural injection and you get 3 months of relief, that's 3 months to strengthen your muscles like to the extent that is needed to get you functioning. So I'm talking about heat. Heat this is a procedure called a radiofrequency rhizotomy. We put needles next to nerves next to the facet joint. So let's say that somebody comes in with an arthritic joint. And we said that these joints in the back are mini joints. Arthritis means the joint loses its space. So if there's no space in these little joints in your back, it's hard to get a needle in there to put medicine. That's when we do this procedure, where we go around the joint and get rid of the nerves that take pain signals. These nerves don't have a purpose except to cause pain, kind of like your appendix. Does nothing but cause problems. So these nerves, we try to burn them through heat. And this is the procedure. It's called a radiofrequency ablation. We have the needles on the back connected to a box. The C-arm is in there. And through the needles, we connect these wires. We test and we burn the nerves. This is another view of the exact same thing. This is somebody's low back. This is the lumbar. And again, the lumbar is named 5 for the lowest one, L5, L4, L3. And this is a needle coming next to the facet joint. And then I connect it to my wires and we burn the nerves. You can do it for low back pain, mid back pain, neck pain, and if people still have pain in their knees and joints, it's getting popular in Europe. And this is the same thing done for knee pain when it's not surgically fixable. We obviously want to fix the problem. And if you can't fix the problem, this is an option. Let me jump back on that. So we've spoken about steroids, we've spoken about heat. Another very powerful, useful type of treatment is electricity. Electricity is a device. So this is, again, the spine. We're looking at somebody from behind. These are the facet joints, my red lines. This is a wire. So we put this wire in the epidural space, that space I showed you where we put steroids. We put the wires in there, and the wires have little electrodes. They're connected to a battery pack, the size of a pacemaker. And that sends electrical signals to the spinal cord and disrupts your pain signals going to the brain. It's called a spinal cord stimulator. There are multiple companies, multiple varieties, and all sorts of things you can do with this. We put the wires in, and then we can program them with Bluetooth and change the way you feel it, change the locations. It's a very, very powerful tool, getting very, very popular. You essentially can put the wires in the mid-back and block pain signals going from the legs and feet to the brain, or you can put it in your neck and stop signals going from your arm. So again, the concept is electrical stimulation in the epidural space. And again, you see how the epidural space is different from the treatment. And that's very important to distinguish, because this is very successfully done. Now, again, typically in a patient, we'd have the two wires going up, and that's the battery pack. Instead of putting the pacemaker up front here, we put it right down next to your low back, because we're the back guys. So this is what we have in an X-ray of the wire. So I told you the wires go into the spine, into the epidural space. You see these little black dots? Those are all electrodes. So each wire has 8 electrodes, and there are thousands of different ways we can program. So we put the device in, the patients come in and sit down, and we have these two dots talking to each other, or sending the electricity in different fields in different locations, and you test things and really get good coverage. Now, in the past 3 years, this is getting more and more sophisticated, where instead of putting it only in the epidural space, we can do something called a peripheral field stimulator, where we can even put it in nerves that are outside the epidural space. Who knows Joe Montana? Do we know him? Yes. I work with some younger scribes who have no idea who he is. Sad, sad world. But so Joe Montana has arthritis in his knees, and he has a device which is a peripheral nerve stimulator. It looks like that. So that's the knee, and we put the wires around the joint in the knee, and essentially you can put a battery in there like a pacemaker. And again, many choices, right? It's like you're buying a fancy car, you're buying a Mercedes and a Ferrari, and you want the vents on one side or the other. So you can have the battery pack in here, or if it's uncomfortable, you have just an electrode, and he wakes up in the morning and puts a little disc-like thing above the knee, and it juices up his knee. He feels great the rest of the day. So this is getting more and more popular in all our conferences over the past 2 years. This is exploding in terms of popularity, variability, and effectiveness. Many different names for the companies, but this is called a peripheral nerve stimulator. Again, same concept, electricity, but instead of the epidural space, in a peripheral nerve. And that's the disc I was talking about, where they hold the disc right above. So essentially, I put in 2 little wires, and I keep that close to the skin. And what you do is you get up in the morning and you hold this right here for about 5-10 minutes, and it kind of shoots electrical current and gets rid of the pain for 6-7 hours. So we spoke about steroids, heat, electricity. Now let's talk about platelets. It's a PRP, very popular type of treatment. What we do is we have you come in, we take some blood, and we spin the blood. And the blood separates into different areas. Red blood, and in the middle right there is platelet-rich plasma, essentially platelets. Your blood's composed of many things. White blood cells fights infections. Red blood cells gives you oxygen. Platelets, they have a lot of different properties. One of the properties of platelets is they send signals for healing molecules, cytokines, and different molecules that come in and help heal. So if you take a knife and cut your arm, not on purpose, but accidentally, then what happens is the platelets will send signals and causing that area to heal up. So what we do is we extract those platelets and put it in different areas of the body, joints, epidural space, tendons, ligaments, tricking the body to think that it needs these healing molecules. And these injections have gotten very popular, very effective. Lots of literature on PRP injections in Europe and also locally. Now, another very common and popular type of treatment is stem cell therapy. You've heard a lot about this, and I want to break this down a little bit because there's a lot of confusion here with stem cell. So what are stem cells? So stem cells are cells that can differentiate or change into other cells, right? Stem cells are the original cells we're born with. So we're born, that one cell splits into many different cells. So we all kind of have that single cell based on embryology that differentiates or breaks up into different parts. At some point, as the fetus is growing, they change, meaning one layer converts into bone and cartilage, other into organs, other into nervous system. That's called a differentiated stem cell. So the idea is, okay, let's take one of these cells and put it into a problem area, and it can fix the problem. So the stem cells also, very similar to the platelets, signal a lot of healing molecules. That is a fact, and that's how a lot of stem cell therapy works today. And if you look at this picture, right, it can reduce inflammation, it can self-replicate, it can differentiate into multiple tissues. Apoptosis is cell death, it can prevent that. So we know for a fact that reducing inflammation happens, it can differentiate, but the idea that when you put in stem cells, let's say somebody has arthritis in the knee, there are claims that you put in stem cell and that it'll regrow your cartilage. That's when we want people to look into that evidence, right? There is no evidence it'll regrow your cartilage. It may signal a lot of healing molecules. It may signal a lot of different things that prevents inflammation, reduces pain. So stem cells can work, but there are a lot of claims out there. And this is unfortunately one of the big areas of controversy today, because I have patients going to Mexico and spending $50,000 doing God knows what, right? So stem cells can be effective, but they're not changing and regrowing stuff. We don't have evidence of that. But it can reduce inflammation, it can help with pain. Someday, in 10 years maybe, they will have the ability to do that, we hope. But think about it. So if we have a cell, all right, that we harvest, and typically stem cells are harvested from placenta, from fat, or the bone marrow, right? Those are the main areas. We take these stem cells and we inject it into the cartilage, and it's going to grow. How does it know that it wants to change into a cartilage tissue, right? Not much evidence for that, but let's assume it recognizes the cartilage of the knee and says, okay, here we go. Let's start replicating and form cartilage tissues. How do we stop it? Why doesn't it keep growing and causing a huge tumor there? You see what I mean? So there are a lot of issues with stem cell that we don't know. But the problem I have is people are charging $50,000, $20,000 from patients who are in pain, who are suffering, who are desperate. So that's why very important, evidence-based. Sometimes people will go and tell you things like, oh, evidence-derived, evidence is in the room, but is it evidence-based treatment? That's the question. And you'll get a no. So these are the different things we can put into your body. And I spoke about the main target areas, which is the epidural space. I spoke about the joint in your back, but you can really put them anywhere, right? So we looked at the where, we looked at the what. The future, exciting. So many amazing new things are coming out in the world of pain management. And for me, I'm really excited because there's a lot of things that are going to change in the next 5 years. This is something called an SI fuse. Remember I said that joint? We looked at the location, which is the SI joint. This is the little device the size of a quarter that we can actually put into the joint, minimally invasive treatment, and it looks just like that, and it's working amazingly for sacroiliac pain. So again, if somebody has really bad arthritis and we put all these different agents in there, but it's bone on bone, this opens it up and fuses it to give you relief. There's some new treatments coming out, and this already exists, where the muscles around the back, the multifidi muscles, and these are very important muscles in stabilization and helping you move and helping you stand straight. The first muscles, they get weak. This device, you put it in there and it stimulates the multifidi to grow. When somebody's in pain and they're not able to exercise, we put this in there, the muscles get stronger, and then they can exercise. So the future is definitely exciting. And as we continue this journey started by our ancestors, all the way from the great civilizations of the Egyptians and the people who have strived to improve the life of others suffering, we're continuing that journey. We have a lot of information today. We have a lot of technology today, and definitely options to prevent suffering and help people reach their goals and live a great life. Questions? Go. I think Brett takes over the question. About
yeah, actually, if we can, if they ask a question, if you just repeat it for the people on Zoom,
okay,
and that way everybody gets to hear it.
All right. Thank you, everyone. Go ahead, man. Question. Yes. Okay. So the question is, what's the risks of treatment? So all the procedures we spoke about, there are risks. And the most important thing is we clean the skin to prevent infections. That's the most common thing. And then the medicine itself has certain side effects. For instance, steroids, they can get you jittery, difficulty sleeping. Those are the most common ones. But once we put the needles in there, there's also a risk of, are we going to the right spot by the nerves, by the blood vessels? So nerve damage, vessel damage, all these things are issues we need to worry about. But it's so dependent on the person. What's their history? What's their anatomy? And when we talk about risks, I always think of, if somebody came to me and said, deliver a baby, very risky, me doing that. You go to an OBGYN routine, right? So I guess the big risk is find the right place, right provider, right diagnosis, right treatment. But again, it depends on the procedure. But those were kind of the basic risks in all the procedures. Question.
So, after treatment, you said the whole point of the treatment is, of course, the immediate pain release, but to strengthen the muscles and to give you time to. So, what is it you do so you don't have a problem again to strengthen the muscles and whatever it is? So you can't really make the discs get better,
right?
Whatever, right?
Right. So the good question. So the question is, what do you do after the treatment to make sure you're doing okay? So a lot of people have pinched nerves, have arthritis, and don't have pain. So that's not really the problem. The problem is something happens and you're unable to function, the muscles get weaker, and then you're in this vicious cycle. So let's say we get a successful treatment, an injection, ablation, whatever it is, then the goal is rehabilitation. It's huge. Working the right muscles, getting in a daily routine, healthy nutrition, lifestyle, and that's a whole change. And it becomes more important for somebody who has had a history of pain. But the problem is, it's a mindset change. And I don't blame anybody for doing this, but I usually have patients come to me and say, yep, time for my injection again. I'm going to go skiing. I'm going to go eat my pizzas and everything, which is great. I love it. But, it's the idea is, I'm just helping your body heal. I'm giving you time to strengthen your body. And that's a very difficult concept. And I think that's why a lot of people do what's the next injection? And people love injections because it helps. But if we have that mindset switch about, help me, help you, what are you going to do? And that's the key. Not to, and when I say exercise and strengthen the right muscles, I have patients come to me and saying, I exercise every day. I'm playing tennis. running. So that's using your body. That's the difference. So the right rehabilitation for your core and your back, the right nutrition, those kinds of things become essential for the 3 to 6 months that the injection works for you. But if we put in something more permanent, like a stimulator, that means that you've been in pain for a very long time. And so a lot of things need to change. And so essentially, in between treatments, we're working on the rehab, we're working on the strengthening. But also, patients have more than one problem. So I might do an epidural and your pain reduces 50%. The facets are inflamed. So that's why people get an epidural, maybe facet treatments, different things. Also, the low back can have pain caused from different things that look very similar. So a high herniation, like an L1 pinched nerve, can mimic arthritic pain. So you can have all the studies and images in the world, but until you go in and put some medicine under X-ray and say, I am putting medicine in this joint, and the patient's like, oh, I feel great. There we go, that's the problem. So fluoroscopy has helped us identify problems, and then we get you to that place where we're in a good place, a good spot. Really need to work on the strengthening, rehabilitation, and that's harder than said. Sir, hey.
When you do like steroids or injections, those are short-term solutions. But when you go for a long-term solution, like ablations, rhizotomies, and these type of things, why would you, a patient want to go for a longer period by having ablation or rhizotomy, or continually having injections, knowing that they're short term versus a long term? And also, you're probably going to come in and say, well, it depends too on a person's age, because it makes it different.
Good question. So the question is, why would somebody want something that lasts longer, like a epidural versus facet? So, good question. So again, it depends on the problem. So if somebody has a pinched nerve epidural, so let's focus on the rhizotomy, which is a treatment in this instance, let's say for the low back arthritic joint. So a facet joint injection, if I put steroid in the facet joint in the back, it can give you 3 months or so. That's a great option for somebody who can get better in 3 months, do their exercises. But if the joint,
someone younger,
maybe, yes,
recover,
correct,
because your muscles, when you're younger, they can recover.
Correct.
As you age,
yeah,
that's not true. So that
Correct.
means that you're looking at statistics. When you look at statistics and you say lower back, we're just talking about the lower back, and you were to run a curve with age,
right,
and if this comes down and you get a pinched nerve, at some point you've got to say, statistics is going to say that, you're better off getting an ablation or rhizotomy, because we know from history,
right,
that the first time you're going to last 2 years, and every time you do it, it's less and less and less.
Correct.
Because the nerve and the brain
yeah.
start to regenerate themselves.
So the question again was, why not do a long-term treatment? And that's what we're moving towards. Even the insurance companies, who, by the way, have a lot to say about what we do and control every single thing for the most part, are also moving to authorize more longer-term solutions like ablations over facet injections.
Good question. It used to be that you could go into your office and get an ablation or rhizotomy, but who changed the, I don't know if this is the right word, the policy that says, no, now you have to go into a hospital to have it done.
Yeah.
Versus we used to go into your office and it wasn't an issue.
Right.
Now the problem is not you. I want you to understand, it's not you. The system changed, so it means now that you have to go into the hospital. So now the wait time is
right. So so the question is, why is there a difference between an office and a hospital? So if we're doing sedation, then they look at all the different risks, and some patients need to be done in a facility where you have a higher care. especially, as patients get older, there's a higher risk factor. Good questions. Let me come back. Give me 1 sec. Go ahead, Brett. Do you have
Yeah, I have one online. Just I have extensive. Hold on a sec here. Another question came in. I have extension DDD in both the lumbar and cervical discs. The cervical discs are the major problem. I get steroid injections, but I'm beyond that now. Will the subsequent treatments you talked about, especially stem cell, have any effect, or is that a possibility?
So the treatments received are not effective. The next step might be something more long-lasting, like an ablation and a rhizotomy. Degenerative disc disease is an arthritic disease. So stem cells, platelets into the joints may be an option. But again, it all depends on the imaging. If there's no joint space or the space is really limited, it is a better option to try to dissolve the nerves than try to put different medicines in there. So that's a very good question, actually, because say somebody has a facet injection in their neck and they're not getting good benefit. That means something's wrong with the facet. Let's say you have a few injections, make sure the technique is okay. So putting stem cells into that joint, again, is problematic because there's no joint space. So it's better to do an ablation than something like that. But again, it all depends on individuals and the anatomy and what we find.
All right, you go ahead in the room.
Go ahead.
The difficulties with multiple steroid injections.
Yes.
Why there's a limit.
So the question is, what's the problem with multiple steroid injections and why there's a limit? So before people knew all these rules, lots of steroids were used. Steroids seems like the miracle drug. But the problem with a lot of steroids, it makes your bones soft. And it also causes you to have Cushing features, meaning people gain weight, hump in the back, affects your endocrine system. Essentially, bad things happen, right? But cataracts, all these different things. But when you're getting injections, the benefit is you're getting a smaller dose localized into the area, less side effects. But even with that, we have to monitor. So anybody getting injections, we're monitoring all the injections, when they have it, how often, but you have a lot more leeway in the number of injections you can have rather than how often you take oral medicine. And there are patients on oral steroids for life, people with different diseases like rheumatoid arthritis, for instance. They have to take steroids every single day. So again, dose dependent. So when they get to a certain dose, their side effects are minimized. So steroids, again, not dangerous, but if we do it appropriately with a good time frame and spacing, we really limit, almost minimize or negate the side effects.
All right, another one. This one's a little different, but it says, long story short, 74-year-old mother fell a few days ago, closed fracture proximal end of her right humerus. The neurology check came back from ER back normal. She's waiting to see an orthopedic surgeon. The big question is, what should we do on the road to recovery in these type of situations in order to reduce the chance of long-term pain? She has osteoporosis.
Well, good, because I'm sorry to hear that happened. A fracture is something that needs to be fixed, especially in the humerus. So you'll have a surgical consult. One of my orthopods will have a look at it. And depending on what they want to do, if they want to put a plate and pin and screw, that will help fix the problem. But then again, we come back to the muscles, right? So if there's an injury like that, what we don't realize is she's probably bedridden and sitting down, not using her muscles for a few days. That causes huge problems. Stabilization muscles are weakened. The big muscles start to get weak. And there's a lot of studies showing that when people are laying in bed in a hospital, the biggest problem is what we call deconditioning, another fancy word to say muscle wasting, muscle weakness. So the main thing for her is as soon as she gets this fixed, muscle work, get up, get moving. And that's why when anybody has hip or knee surgery today, they're up walking the same day. And that has shown to have amazing outcomes in terms of recovery and getting back to activity. So again, sorry about the fall. That's terrible to have happened, but get the right surgery, get it fixed, get back into mobility. In the initial stages, very important to have good pain control, because again, the problem is you're in pain, so you're not moving, and that makes it worse, right? So again, that's when we want to really get aggressive with the pain medication. And unfortunately, we have this weird world out there where because of the opiate crisis and epidemic, now no one's giving pain meds. I had a call the other day from the ER. It was a resident, not Eisenhower, but a resident who this kid, 17-year-old kid, had a spiral fracture of the femur. That's a big bone. Spiral is a huge fracture. And he called me and he's like, yeah, I gave the guy some Tylenol. He's upset. I'm like, you know. So we need to aggressively manage pain in the early stages so that people can function and restore their muscle tone and mobility.
All right. Any other questions in the room or online? Looks like you might have one. Hold on a second. No, I think that's it. Everybody's just saying thank you. Well, one in the room.
Oh, sure, go ahead. Yes and no. Yes, big answer, yes. But if you're having osteoporosis and osteopenia, those are serious conditions that need to be managed. So you need to be on, obviously, the right dose of calcium, bisphosphonate, inject. So that's a condition that needs to be managed and monitored. So if you're trending upwards on the DEXA score, which is what they look at, the DEXA scan, and those results, if we're showing positive improvement, we feel more confident doing these injections, especially if it's going to help you. Because for osteoporosis and osteopenia, weight-bearing exercises are huge. So if you have pain and you're sitting around, it's not going to help you. So get on the right medicines, get that disease condition moving in the right direction, and 1 or 2 injections just to help if needed. And again, injections are not the complete solution. I'm not saying that. And the very first slide I showed was that comprehensive treatment, right? And today we focused on the direct treatments, but of all my patients, only about 35% or less get injections. My big message is muscle work, core strengthening, back strengthening, lifestyle, behaviors, right? Those are the things that we should be worrying about and really focused on, because we're in a society where people forget that. We forget, and there are many things, nutrition, processed foods, whatever you want to call it. But if we get those things under control, the injections are not even a thing. But good question.
All right.
Awesome.
Good
question.
Okay. If to do ablations, now you have to have sedation. Okay. My question is going to be, has the medical industry then, because they changed the policies and the rules where you have to have it done in the hospital if they're going to sedate you, why can't you do like a dentist does before they do pull the tooth out? They give you a minor injection so you don't feel it. And why can't you do the same thing when you're going to do an ablation? And I'm thinking you're sedating somebody because of the pain.
Right.
Why can't you do a free pain so that you don't have to do that? So that you don't have to go into a hospital and continue to do it.
Yeah. So the question is, can we do ablations without sedation? Yes. They do it with local anesthetic. But the problem is each needle, and again, you're sedated, it goes up to about 180 degrees Fahrenheit next to the spine. It's a little uncomfortable. We put a lot of local. Some people can tolerate it fine. I've done it with local and numbing. Some people can't stand it. So that's the distinction. And we do. So even if I sedate somebody, I still use a lot of numbing medicine. And again, that comes down to like the person and the individual and hospital based on needs.
But trying to get into Eisenhower to get that done.
We can talk. We'll figure something out. All right. Thank you.
Well, Dr. Cassim, thank you so much.
Thank you, everyone. Good job.
Appreciate it. Everyone have a great night. And for those online, this is recorded, and as I said, we'll add closed captioning as well. When we do all our recordings, they automatically include closed captioning, so we can capture all that. Thank you so much.